will be live.
Okay. Can you just tell me till that time passcode and meeting ID, because I'll be starting with the laptop once again, and actually I'm doing it on my mobile, so I do not want to disturb the slide once again.
Okay.
Just send me meeting ID, passcode and
Yeah.
meeting ID, because I'll be starting with the laptop once again, and actually I'm doing it on my mobile, so I do not want to disturb the slide once again.
Okay, so we are live now.
Then we are live now. Now we are live.
Yeah.
Because I'll be starting with the laptop once again, and actually I'm doing it on my mobile, so I do not want to disturb the slide once again.
Okay, so we are live now.
Then we are live now. We are live. Yeah. Because I'll be starting with the
इसको लेके जाओ इसको डैडी टेक हिम ही इज द बॉय ही इज द बॉय मोना तुझे कुछ खाना है खा के आ रही बोल तो रही है 500 रुपए का बिल बना के आई हूँ और फ्रेंच फ्राइज खाया फिर उससे भी पेट नहीं भरा तो कहीं तो पाव भाजी भी खा के आई हूँ और बोलती है जब मैं पूछूंगी तो बोलती आई वांट गाइड मर्क्यूरी He wants to Mercury to Mars and then Jupiter. आपको कुछ खाने का है? तुम तो गिर रहे हो ऐसा लग रहा है अभी गिर जाओगे तो नहाने में आप क्यों ऐसा अंदर जाते हो? भाई कल छुट्टी है आपको अभी तो बोलो मत कि शाम में आपका लेक्चर है क्यों पूछे लेके आओ ना पता है ना आपको क्लैप योर हैंड इफ यू हैप्पी एंड यू नो इट भाई 12 बजे भी लेक्चर नहीं वो 1-2 बजे मैसेज इफ यू हैप्पी एंड यू नो इट क्लैप योर हैंड इफ यू हैप्पी एंड यू नो इट स्टैम्प योर फीट इफ यू हैप्पी एंड यू नो
Aditi ma'am, can you mute your audio for 1 minute? Aditi ma'am, can you mute your audio? Yeah. So hello and welcome to a new webinar of Asian Eye Hospital Knowledge Series 360 degrees. And today we have a special guest with us, Miss Aditi Deshpande. Now she has been in this profession for I think over 15 years now. And she is a fellow of American Academy of Optometry. She has completed a master's from Bharati Vidyapit University, and she is also a fellow of IACIL. She also recently was awarded the Dr. APG Abdul Kalam Lifetime Achievement Award for her remarkable achievements in teaching, research, and publications. Her passion lies in binocular vision and orthoptics, and she has been a fantastic educator. So basically, we have started the meeting now. And we welcome all our viewers, and Mrs. Aditi Deshpande today is going to talk about binocular vision and the common anomalies that we see in the clinic. And we are going to take it forward from there. So first of all, welcome Aditi ma'am to this webinar.
Thank you, Husain, for a nice introduction. It was a great pleasure to be interacting with you all. So I would like to take you through a small presentation, which will I definitely want that everyone be interactive during the session, because I know that this binocular vision, when you learn in your optometry, that time you just learn as a subject, but when it's a application part, so when you start your practice, so nobody will think of doing this that as an option
Yeah.
or as a specialty during your optometric practice. So it is not like that every time that you should have a special instrument to diagnose the binocular vision anomalies. The simple instruments, the simple things that you can improve in your routine eye examination, which will definitely stand out as an optometrist, a special optometrist in our current scenario. So I would like you to have a interaction during the session. So whenever you want any things that want to ask, you may interrupt in between. So we'll start with
So
a
we have
small,
chat also. In the chat, you can post your questions. At the end of the session, we would take that questions.
yeah.
Okay. So meanwhile, while Aditi ma'am is sharing the slide, I would just like to share a funny incident. In our third year, we had a orthoptics textbook called Keith Light, Practical Orthoptics, and we had not actually seen the textbook. And during the exams, we heard from somewhere that the questions are going to come from Keith Light, and someone got the book from the library, and then we were just going through the books, and we were like, "Arey, ye to ho gaya hai. Arey, ye bhi ho gaya hai." So in fact, all the topics, all the practical topics were covered in Aditi ma'am's lectures, but we did not know it was from such an important book. We thought actually it was from the lectures itself. So her quality of references and the way she teaches the practical aspects along with the theoretical, which is very difficult when it comes to orthoptics. Even experts in the field, falter when it comes to explaining the practical aspects of orthoptics. That was one of the highlights of our optometry school.
Uh, it feels very honored that if a student is actually practicing orthoptics, and now I'm seeing that the students are going abroad, or they are calling me from there and asking me that, madam, this you have taught us, and now I wanted that some suggestions from you. So I feel so proud that the students are actually practicing orthoptics in their clinical practice.
Definitely.
So I
Yeah.
wanted to just talk about that binocular vision. So the word itself is terrifying. So sometimes you feel that why we need to do the practice of binocular vision in your routine practice. So uh, seeing seeing the image as one, it doesn't call it as a binocular vision. So when you talk about the binocular vision, perceiving the image in three-dimensional way is what binocular single vision is. So patient says that, मुझे तो दिख रहा है सब कुछ. I'm seeing everything as clear. But seeing the things that clear and perceiving the image in a three-dimensional way, there are two different aspects of binocular vision. So binocular vision itself is a huge terminology. So having the binocular vision will give you a larger field of view. So as I told you that the seeing the objects in three-dimensional way is your binocular single vision. So that is means you're having the depth perception. And most of the times when you have a binocular single vision, definitely your different aspects of visual performance, visual functions like visual acuity, then space perception, hand-eye coordination, body-eye coordination would be increased. So definitely having a binocular single vision is as if you are having everything with you. But if you see that where in 90% of the cases, when the patients are coming to your clinic, they say that I'm coming for the routine eye checkup, or sometimes they have a refractive correction, but still they don't wear it and they are complaining of the headache, eye strain, like that. So you should click, it should be clicked in your mind that the patient, apart from the refractive correction, the patient might have some kind of binocular vision anomalies. So I have categorized binocular single vision anomalies into different parts, like strabismus related, then non-strabismus related can be accommodative or Virgin's dysfunction. Then sensory adaptation to the squint can be ARC or suppression. Then vision deprivation could be amblyopia, and the eye movement disorder could be nystagmus. So here, very commonly seen binocular single vision anomalies are non-strabismic related. That means accommodation and convergence disorder. And very commonly seen in children, which is amblyopia, that are vision deprivation. We call it as a vision deprivation binocular vision anomalies. And strabismus, yes, strabismus means that if you have a Virgin's problem, so the latent squint can be present in the patient. So strabismus in the binocular vision anomalies, in strabismus, you find comitant squint will be very common as compared to incomitant squint. So where I have circled the some of the common binocular single vision anomalies. So are we actually considering or classifying the age group for binocular single vision anomaly group or for orthoptics checkup? As we are going for the children, or we are going to do the checkup for the college age students or even seniors. So not no as we cannot classify this age group. So any person at any age can face this problem. So you don't have to think, now this child is of 10 years of age, he might have a binocular vision problem, then I have to go for orthoptic checkup. But the person, if he's coming at 50 years of age and having a complaint of headache, eye strain, apart from his refractive correction, the thing you should click in your mind that no, he is also a person that can be categorized as binocular single vision anomaly. So we should not classify this according to the age group. At any age, this binocular vision anomaly could be there. So normal refractive condition patients may also complain that I'm having headache, then sore eyes, eye strain, then I'm working on a computer for last 15 hours. So I got tired. I will get tired after seeing the long exposure to the screen. So these complaints will tell you not only the patient will have a refractive correction, but also binocular vision anomaly could be possible. So what are the conspicuous difficulties experienced by the children? They can have a lack of social smile because what happens when the children goes in their surroundings, then they may not able to perceive the image clear, or they may not. So if they are lacking with the three-dimensional view, so they may not able to catch the ball. So if they are there in the social environment, they will lack all these things. So automatically lack of social smile will be a consequence of lacking of binocular vision. Squeezing of eyes, inability to see the blackboard, all these symptoms are, I know, related to the refractive errors. But refractive errors, apart from leaving the correction also, still you feel that patient is not comfortable with the correction. The parents are complaining that the child is not wearing the glasses continuously. So then in that case, your answer should not be the adaptation. So 90% of the practice, the practitioner will suggest you that because you are wearing the glasses for the first time, it will take some time. 15-20 minutes are enough. 15-20 days are enough to adapt with this spectacle. उसके बाद आ जाना clinic में if you are having a problem. So what parents feel that no, children are complaining because they do not want to wear the spectacle, but this is not so. They are having actually problems. So after wearing the glasses also, they are not comfortable with the glasses. Still headache, eye strain is still there. So that will give you an indication of the children may have a binocular single vision anomaly. And the consequence is what? There will be a poor school performance, a lack of attention, Then sometimes the teacher may complain that the omission or doubling of the letters, confusion of the letter he might see from the other's book. So these are all the consequences of your binocular single vision anomalies. Then even in adults also, these symptoms are very common. So after you prescribe the correction also, still patient will have a problem of blurring of objects for a after prolonged exposure. Then there would be the eye strain, dizziness or nausea would be there. So we should be very clear with this concept that we should be treated or referred out for the treatment of these frequently but often ignored disorders. So that means when the patient is having the binocular vision anomaly, that time you are supposed to treat the patient or you are supposed to refer out the patient for the other practitioner or the optometrist in a such way that it should be treated properly. So I think I'm pretty clear with the symptoms which are associated with the binocular vision anomalies. So anyone would like to have a question on this? Till now, I hope I'm pretty audible or clear with the concept of how the binocular single vision anomalies could be associated with your normal refractive conditions.
Yes.
So the one thing we should clear in our mind that you should not feel that now I have to waste extra time, extra money to rule out this orthoptics evaluation. No, never think in that way because it will take a few minutes to just do the evaluation of orthoptics. So that means what are the things you should include in that? Is there any other instruments, extra instruments you will be buying for it? Yes, few of them are yes, but few of them are not mandatory also. So like cover test. Why cover test is important? As I told you, cover test will quickly give you an idea about whether the patient is having choriotropia. And it doesn't require much, a few minutes also. It actually gives you an idea within a second's time. And it requires only two instruments. One can be torchlight and the other could be occluder. So occluder is easily available and the torchlight is also there. So once you are doing the cover test, it gives you a quick identification whether the patient is having phoria or tropia. So phoria means a hidden squint and the tropia means a manifest squint. Then along with the cover test, if it is possible, then quickly do the assessment of the muscle balance with the help of ocular motility test. And accommodation convergence is very important because if you see any profession, and if you have seen this in the COVID pandemic, most of you are there on your laptops more than 10 to 12 hours. Apart from the people who are working in the hospital, otherwise all of them, all the professionals are on the laptop more than 10 to 12 hours. So this problem is very common nowadays, that patient is complaining of headache, eye strain after working so many hours in front of the laptop. So being a refractive correction, why this problem has occurred? Because your Virgin's functions are not properly working. So your muscles are having some problems. So what are these problems? That can be convergence, less insufficiency can be there, or patient may not accommodative, or he is extra accommodating while working on the computer. So anything could be there. Okay, so in this case, you should assess at least accommodative and Virgin's function. Grades of BSV will give you an idea when you do the cover test and accommodation and convergence function. So you don't have to require the synaptophore in practice every time to test the grades of BSV. So you can quickly assess accommodative function. NP8 is very easy to do that. It is done with the help of RF ruler. So you can see in the slide, There is a RF ruler, which is there in the third slide, which gives you the assessment of NP and NPC, and that not cost much as well. So along with the retinoscope, you can definitely buy RF ruler and the prism bar for this binocular vision assessment purpose. So the first diagram is a representation of your Hirschberg test and cover test, which actually tells you about that how this phoria or the tropia can be seen with the help of cover test findings. Then fusional versions motility test can be done easily to assess the muscle balance. So I hope this concept of assessing your sensory and motor evaluation has to be performed by every optometrist during its clinical practice. It should be a part and parcel of his routine eye examination. So once the refractive correction is done, you are asking the patient to sit on the slit lamp. But you are not doing this simple test, which may have a problem, which might create a problem for the patient after the correction as well. So patient has won the correction for so long time, but still he is not happy with the correction because he is suffering from sensory motor anomalies, and that's the reason you are supposed to evaluate those after giving his refractive correction. So before you perform the slit lamp examination, I want you to quickly do this test and just assess. And patient will also feel that, yes, he has done something extra to me. And he has also asked me the some important question that can be ruled out after wearing the correction also. So this is where your skill works, or you will be standing out and than that of your other optometrist.
Yeah,
And stereo
actually,
acuity,
that's a very
yes,
important point.
yeah,
What we see in clinics, even in institutes, is that only in the pediatric department or in the orthoptic department, these tests are done. But
yes,
there are general patients also who come with a complaint of headache or some kind of fatigue at the end of the day, and we just the common practice is to provide them some kind of drops to comfort. We assume that it's dryness, it is strain, but we do not do these basic tests. These are pretty easy. It's there in any textbook. You just pick it up and it's there.
yes, yes,
Should be mandatory for all patients.
yes. So stereo acuity for, yes, I do agree that everyone may not be having this stereo acuity test cards. So they may not have this Titmus stereo card test. Okay, it's not an issue. So, but what you can do is that you can quickly hold the two pencil and ask the person, try to hold the pencils in a such way that the tip of the pencil should be matched binocularly. Okay, that will be a quick assessment of the stereopsis. So it is not necessary to buy the stereo acuity cards every time to rule out the binocular vision anomaly. So after that, yes, definitely if you want to start a separate orthoptics clinic, orthoptic clinic the start karna hai, then you may think that yes, I should have the list of the instruments with me. But routinely you can at least do the investigation of stereopsis, or at least a patient, if he can have a gross stereopsis or not with the help of this gross pencil test. So that is called as Lang's pencil test. Then third point, you are doing the refraction part. You are using red and green filters. It is not just to keep it in your trial frame. You have to use it for at least 5 minutes. What is the use of that red and green filter? Definitely you can use it to check the separation. So after prescribing your prescription to the patient, you can quickly put the red and green filter in front of the glasses, and you cross check it whether the patient is having binocular single vision or not, whether the patient is suffering from diplopia or suppression, or he will be having BSV, or patient is normal. So this, a quick assessment can be performed during your routine eye examination itself. So, and why I'm emphasizing those tests because you are not requiring extra inventory for that. You are just using your trial set. You are using the lenses for the refraction part. Then why can't you use those red and green filters for assessment of your binocular vision? Why can't you use the Medox rod? So if you are not comfortable with the cover test, so cover test ke alawa you can use the Medox rod. So Medox rod will also give you assessment of dysphoria and tropia evaluation. So this is how you are going to not impress the patient, but this is how you are going to explain the patient this test, why these tests are important for you. And this he will also feel that yes, he has done something extra to me. That means that he is understanding me. So understanding is very, very important in the case of binocular vision assessment, because patient has gone to n number of clinics. There are n number of the hospitals where the patient is going. This is not the first time that the patient is coming to you, and he will stick to you unless and until you will perform different special things to him. Otherwise he is having multiple options. So he can go to the one optometry clinic, and at the next time, if he is not happy with that customer, if he is not happy with that service which you are providing to him, he will go to another shop, he will go to another optometry clinic. So if you want to retain that patient, you should be have a thick background or the thick line which will differ you from others. So that's why our goals should be detection and elimination of these sensory motor anomalies. We need to identify what the patient is suffering from. So we need to improve our sensory motor visual skills. Unless and until you will give the treatment, only detection will not help you. So detection is one part, and you have to treat that anomaly is the second part. So treatment is as important as your diagnosis should be. So after detection, after diagnosing, the management part, what you are doing the treatment to him, that is also important for him. So treating him and establishing the binocular vision which improves the patient's quality of life should be the goal for optometrist. So treatment. So now you will think that we have done the testing part, but how I decide that which patient should be treated for which binocular vision anomaly? So we call it this treatment plan as vision therapy program, which improves the overall visual functions, including the visual acuity, then depth perception, then visual performance means the body-eye coordination and hand-eye coordination. So this can be given as home-based as well as office-based vision therapy. So it is not required that the patient can be there in the clinic for so long time and you are giving the treatment. It is not mandatory every time. So you see the binocular vision anomaly and you decide that if it is feasible for the patient, he can do it at home. That's the reason we want that within small inventory itself, how we can give the best treatment to the patient. So now you have a patient of amblyopia. So say a child of 10 years of age, he is suffering from amblyopia. So one thing that you should click in your mind that now he has amblyopia in a uniocular in one eye. So patching can be given to the patient to improve the vision. So bad eye can be used for vision and the good eye can be patched. In that case, so you can see in the slide that I have there are some puzzles or there are some drawings which are being mentioned in that slide. These are the drawings can be given according to the age. What happens in the amblyopic child or the amblyopic patient that he will have the crowding phenomena. Crowding phenomena means the letter R get jumbled. This is in a common term, we call it as jumbling of the words is called as crowding. So he may not able to identify the space between each letter. So because he cannot identify the space in between each letter, all the letters are getting jumbled, and he won't able to write at all. So he will think that I don't want to write, or the child may complain to the parent that I don't want to write anything, or he may try to see it from the other's book because all the things are getting jumbled. So for those patients, if the child is of uh, 5 years of age, 10 years of age, you can modify your sheets. These sheets are easily available on net. You don't have to make it by yourself, or you are having a newspaper with you. In the newspaper, you have a kids section. In that, on every weekly, there will be a section of kids where the puzzles are there. You can ask the person, or you can ask your child who is amblyopic, patch the good eye and do that drawing part. Then any activity which is there in the newspaper, or if you are having a multiple books which contains the puzzles or the drawing, you can ask them to do that. And in between there is one thing which you can ask the child or the person who is amblyopic to strike the letters. This striking exercise is very essential because the person is amblyopic and he is having crowding phenomena. So the striking letters would be a best exercise at any age for amblyopic patient. So this is how you should think of giving the exercises. So इसके लिए कितना inventory लगेगा? I don't think so कि taking the printouts from your just Google will take maximum of 10 or 15 rupees, more than that. So I'm not expecting that everyone should be having their computerized vision therapy with them. No, it's okay. If you are not having it, you cannot stop seeing the patients of orthoptics. You can definitely check out, you can definitely diagnose it, and you are having more instrument than this, like heart charts that can be also given in patients who are having binocular vision anomalies, like flippers. Flippers are very easy to manufacture as well. So if you are having two spectacles, just uh, soldier it with different lenses. One is with the plus and one is with the minus. Only thing that the power should remain same. So either you can buy it from the manufacturer, or you yourself can manufacture a flipper. So these can be given in patients who are having accommodative anomalies. Heart charts are very simple to use it. So you can make a different, you can take multiple heart charts, can be of various distances or can be of various size also, and that can be put up at various distances depending on the patient's condition. Pegboard rotator nahi hai aapke paas. What you will do then? Will you stop giving the exercises to the patient? No. Then you can give, improves the eye tracking ke liye you can give the Marsden ball. So binocular therapy means what? When you are having a binocular therapy should be given to the patient, make sure that his both eyes should open. That means amblyopia में अगर आपको binocular therapy देना है, that means patient is not wearing any kind of patch during its treatment part. So you can give with the help of different instruments like bar reader, stereoscope, or diploscope in cases of suppression, or who is having diplopia complaints. Here in the bar reader, I do understand the stereoscope or diploscope will take some time to understand the concept. The practitioner should understand the concept behind the stereoscope, diploscope. Fine, you do not want to use those instruments, you may not use that. But bar reader, अगर patient को problem है suppression का, if the patient is actually suffering from suppression, then bar reader will actually allow you to remove the suppression and start establishing the binocular vision. So how this bar reader works? You are having a transparent sheet. So you can make a transparent sheet in which you can have a equal widths of red and green lines can be drawn, and the patient has worn the red and green filters. If you do not want to use a red and green filter, you can just draw the lines with the black color. Okay, black marker, say you can draw it, you can draw the equal width, you can draw the lines of equal width and try to ask the patient to look through this transparent sheet, and you can have a reading material below that. So what will happen if the person is having a suppression? He may not able to read the gaps under the letter. The gaps which are there, behind those the letters are being written, that cannot be readable by the patient. But if the person is not having the separation, binocularly he will read out the letters behind the bars. So what we have to achieve is, we have to try that patient to use the other eye in a such way that he will try to see the letters and the bar are double. That means he will be out of separation zone. He will be trying to be out of separation zone when he will try to see the letters behind the bar. He has to forcefully use the both eyes so that the suppressed eye will start working, and then he will be seeing bar as well as the letters behind the bars are double, and he will start using his binocular vision, and automatically the patient will be out of separation zone. So this is simple. This is very simple. Stereoscope, diploscope will take time to understand. I know that we have a little bit a lesser of time, so we cannot able. I'm not able to explain the stereoscope and diploscope in detail. But definitely, bar reader would be a best exercise for the separation patients. So you can see that I have mentioned some of the pictures which are easily made. And very important and the simple string which I love in my clinic, I give to every patient is your Brock string. Brock string is very easy to manufacture. Not a 5 minutes of time you will take to make the string. Not even a 5 minutes. You have to take a string and put different beads in that. The beads are of different colors because the different colors will stand out, and the patient will be seeing different beads at each point. So try to use a different color, and the beads should not be of a lesser size. A little bit bigger size beads can be taken, and you can use this for any kind of accommodative convergence anomalies. So you can use this for divergence exercises, you can use this for the convergence exercises. So to train the patient with separation, because he has to convert the separation from seeing the diplopia and diplopia to single vision. So Broxting is very good instrument, I say that, and you have to use in your clinic. And once you see that how the patient is responding and how the patient is out of that anomaly, the satisfaction on the face, it really makes you proud that yes, I have done something different than the other practitioner. It's okay that aperture rule and vectogram still requires more training, because unless and until you are trained enough, you are not going to give this to the uh, your patient. But Broxting, yes, definitely you can give this as an home-based therapy as well. And the stereogram cards. See, the pictures are available on net. You can just type stereogram cards. Your picture would be there on the screen. And are these really helpful? Yes, you can ask the patient to hold the stereogram cards in front of you, hold the pencil in between, try to look at pencil and the stereogram cards on which the cats are being drawn. Look at the cats, try to make out those cats infused into one. So you will be seeing either 3 cats, or you will be seeing the 2 pencil tips of the tip of the pencil can be seen as 2. So this is how you have to move, jump, from one target to other target, which will definitely improve your convergence and divergence demand. So transparent cards should be useful for divergence exercises, and convergence exercises you can use opaque cards. So I must say that you should make stereogram cards. Marsden ball is very simple. You have to just take a ball which is normally used by all children, write down the numbers over it, but numbers should be visible enough, and try to hang it at anywhere in the clinic. And now when the patient wants to improve his saccades and pursuits response, what it has to be done? You can just move the ball from one direction to other direction in a such way that you can be, or the patient would be telling the letters or the numbers which are there on the Marsden ball and can be readable very quickly. So these are your fast jerky movements of your eyes you are seeing from the patient's point of view. So automatically the saccades are improving. So you are working only on, you are not working only on one instrument, you are working on multiple instruments, and you are diagnosing the condition and giving the treatment for those conditions. So see how much time you are investing in that. This is the main important question. Once the diagnosis is done, it is mandatory to at least explain the exercises to the patient. Okay, so prism bar, if you are having a prism bar, or if you are having a flippers, and if you don't want to give the flippers or prism bar to the person who is having binocular vision anomaly, then you can ask them to do it at least twice, thrice week in a clinic, and then the cat cards or the bar reader, Broxting can be given at home so that your balanced therapy would be there. That means you are giving the exercises at home as well. You are giving the exercises in the clinic itself. The last important thing that I was talking about, that computer vision therapy. If you are willing to buy the computerized vision therapy program, you are welcome. But it includes everything. You don't have to make all the instruments if you are having computerized vision therapy program. But main thing why I am not suggesting, I'm not for it, is because compliance part. The child may not sit in front of the computer for a prolonged time for the exercise purpose. If you are asked him to just turn on the camera or turn on the video, you may start playing the video. Yes, he will definitely sit in front of the computer. But if you ask them to do as an exercise, he will not sit. So we have to make sure that the child will be sitting in front of the computer. For adults, there won't be any issues. I do not see any compliance part in adult age group in computerized vision therapy program. It includes everything that you just have to click the program on which you want to work. There are red and green filters, you have to wear it if you want to have binocular vision anomaly like separation or vergence. So if you want to increase the vergence demand for the patient, just click the program and it will start automatically. The instructions are being given. But sitting at one place for so prolonged time will be of time consuming and will be the child will be tired as well. So for children, I may not suggest this computerized vision therapy program, but for adults, definitely yes. But if you do not want to invest on this, please do not skip the practice. I'm definitely not for it, but that doesn't mean that you have to skip the practice because you are not having the computerized vision therapy. I know that the cost is pretty much, it is cost effective. uh, every person may not able to buy that software. So because you don't have a software, you don't have to do the specialty practice. Don't do like that. So even a small equipments can diagnose binocular vision anomalies, and you will also treat the binocular vision anomalies which satisfy the person or the patient's demand. So I have a case. Before I'm going to the case, uh, anyone would like to ask any questions?
Yes, if there are any questions, please do type in the chat. I really like the last point that you made, ma'am. The one about computer vision therapy. So now it's become a trend of sorts where the
Yeah.
office vision therapy is being converted into a computer vision therapy. But
Yeah.
the thing people don't realize is that when the person is in the office, in the same time, there is so much of potential for manual vision therapy which an optometrist can do who isn't sitting in front of you.
Yes.
So in fact, this computer vision therapy is supposed to be done at home at the convenience of the patient. But we see that the computer vision therapy is being done in the clinic. Whereas in the clinic, there are so many other instruments, so many other therapies that we could manually also, we have the prism bar cover test, and through that we can give versions exercise to the patient. We are losing out on that. Why? Because students are directly being given the computer vision therapy option, and that is what is trending right now.
Yes.
So I think there are very few people like you who are actually still adamant about learning the manual vision therapy procedure before going and assessing whether this vision therapy software is good for that patient or not.
Yes. So I think that software being an advancement in this new era, uh, you should not forget our basics.
Yeah.
That is what I feel. So I know that ki software is very, very important nowadays, and it will create an impact on patient as well. But many times this factor will be a obstructing factor for the first time uh, practitioner to start with orthoptic clinic. So they may feel that ki, because I'm not having the software, then why should I start the orthoptic practice? So let it be. So I will just do the manual routine eye examination, and the dispensing part I will continue with. So that point where that we should convince, or we should convey the message to the practitioner or the optometrist for the first time, if they are willing to practice orthoptics, you should not forget these basic investigations, and you can do that in your routine practice as well. You don't have to buy much of the things. So in, because first time the person who has started the clinic just a few days back, he may feel that ki, why should I invest more, because I will be getting money from the counterpart. This is the most important thing. The concept is still there in optician's mind, or where they are getting the money. I am getting the money from counterpart, so I should be doing that part first. I will be focusing that part first. The second part, the orthoptics evaluation, is the secondary to me. That should not happen. Being an optometrist, your mind should be 360-degree focused. So like your program, what it says, that optometry 360. So I feel in the same manner that you should think in 360-degree manners, that no, I can do dispensing, along with that I can do orthoptics practice as well.
Right. So I think there are no questions as of now. We can move on to the case and maybe take some questions at the end.
Yeah, fine. So this was a actual case. I've taken these cases from my practice itself. There was a 23-year-old IT professional came to me, and he was reporting of that complaining of sore eyes, headache, and blurred vision with the near task. So I did refraction part. That refraction part, when I did it, then I found out that the patient is not having any kind of refractive error. And because he was an IT professional, I thought that definitely he would be working in front of the computer for more than 10 to 12 hours, and the same way he had explained me. So without wasting a single time after refraction, I directly move on to the uh, orthoptic evaluation, which did not take more than 10 minutes for me. It's not like that every person might take a different time zone for orthoptic evaluation, but simply cover test and ocular motility, and your NPC will not take maximum more than 10 minutes. You actually count the time, that how much time do you require for proceeding for the cover test, ocular motility, and NPC finding. So I did that, and I found out that patient had a cover test finding was exophoria for the near, and his near point of accommodation and Virgin's NPC was receded, and it was receded much than that of expected. And it was Virgin's facility is also important factor. While we check the accommodation and convergence response, Virgin's facility is checked with help of Virgin slipper. Like your accommodative flippers, we also make prisms which are in the form of base out and base in, which has to be flipped to assess the Virgin's facility of the patient. So I guess that be a important part in the orthoptic evaluation, but it is not mandatory again that you cannot assess or diagnose the condition if you do not have the Virgin's facility. NPC अगर आपके पास RF ruler नहीं है, if you do not have the RF ruler, you have a pencil or pen with you. You can quickly do the pencil push-up test and see to it that how the Virgin's demand of the patient would be. So I did the step Virgins with the help of prism bar, and I found out that there was a huge difference between positive fusional Virgins and the negative fusional Virgins, which was almost only for the near it was 25 and 20. Breakup point was 25 and the recovery point was 20. So this shows that the patient is having, anyone would like to tell the diagnosis part, because now many of them, they might have understood the concept of binocular vision and its anomalies. So anyone would like to tell me in this case, how should I proceed?
Yeah, please type. So someone has said accommodative infacility.
Okay, so you have seen that the accommodative facility was less with the flippers, but you need to also see that the patient's accommodation response was less compared to the, as well as the Virgin's response is also less. So
Yes.
you cannot only say that the patient is having accommodative anomaly, you have to think about that patient's accommodative response is less along with the convergence demand. So your accommodative as well as convergence insufficiency would be the diagnosis.
Yes. That's
Facility
correct.
would
Actually, he has
be,
written along with convergent insufficiency.
yes, right.
That's
So, so you need to rule out all the factors. It's not only that your near point of accommodation is less, that means the patient has accommodative insufficiency. You should not diagnose in that way. You should correlate all the points, like NPA was less, along with facility is also less. Then Virgin's facility and your NPC findings were less, along with your step Virgin's response. So all the factors combined will tell you the diagnosis part. That means the patient is suffering from accommodative and convergence insufficiency. So in that case, definitely I told you the treatment option. I prescribed them the refractive correction, because the refractive correction was nil in that case. So I did not force him, but sometimes some practitioner is also think of giving some correction to the patient, like minus lenses could be given in this case to improve the accommodative response. But this is not the first point that you should be prescribing to the patient. मैंने बहुत जगह पे देखा है, many of the practitioner they will be prescribing the minus lenses for the accommodation. So giving the minus lenses to the patient, definitely it is a option for accommodative insufficiency patient. But what happens with that case? Is he wearing throughout the day those lenses, or is he wearing for only the near work? And he has accommodative insufficiency. So when the patient is having accommodative insufficiency along with the convergence insufficiency, are these minus lenses going to help throughout the day? So for me as a practitioner, I won't suggest for the first time minus lenses won't be working in that case. You should give the treatment in the form of Brock-string, then flippers, heart charts. So that should be your first response, or that should be your first management option in that patient. After that, you can prescribe minus lenses if patient wants that. Before that, I would definitely not suggest minus lenses to be prescribed to the patient who is having convergence and accommodative anomalies, because again the question is, you are not monitoring the patient throughout the day, right? So you don't know that how the response of that minus lenses with the computer, and when he is not using the computer, what will happen when he is looking at the distance? Again, he may not relax the accommodation for the distance. Again, it might lead to the accommodative lag. He is accommodating for the near, but for the distance he is not accommodating, or he may not be relaxed to his accommodation after removal of the glasses. So again there is a lag of accommodation. So these are the common problems associated with prescribing the minus lenses for patients who are having accommodative insufficiency as well as with convergence insufficiency. So I personally don't recommend those as a therapy for the first option. Once you are retaining with a good amount of step versions, or NPC is improved little bit, then you can think of giving the minus lenses to the patient, but not as a first option. I think this case is clear to all of you. Anyone wants to ask regarding this case? Otherwise, I'll just wanted to add one more case.
Yeah,
There was one boy who was 10 years of age. He was presented to the clinic with complaints of squinting of eyes. The parents were complaining that he was squinting his eyes while looking at the near objects. Because I've seen the multiple patients of convergence excess type of esotropia, I could get an idea that the patient is having accommodative esotropia. But still, you should not be confident enough unless and until you have done all the investigation part. So I did the investigations after doing the cycloplegic refraction. So see, doing the cycloplegic refraction in binocular vision anomalies patient should be ideal. But again, it depends upon where you are practicing. So if you are practicing in the hospital, it can be possible. But if you are doing it in the private clinic, then or it's your own practice, then it is, unless and until you are having a consent from the ophthalmologist, you may not perform the cycloplegic refraction in children. So be careful while performing the cycloplegic refraction. Once you are done with that, you should checking the patient's refractive correction. I got the hyperopic refractive error, but it was less. So after giving the correction, also the patient's vision was not improving in the left eye, and he was still squinting while looking at the near object with the same correction. The amount was less, but still the patient was squinting through the correction, and he was appreciating the letters were double. So he was seeing the letters as double. So he was, for the near, he was having diplopia. So I did the cover test. I found out that the patient is having esotropia, left eye esotropia. When I did the alternate cover test, it was going alternate. And definitely, when the patient is having diplopia, you may not perform the NPC NPA test. NPA can be possible, but NPC was not possible because he was having overconvergence. Because of overconvergence, he was squinting, and that's the reason he was appreciating diplopia. The main concern I was having that he was 10 years of age and he was having diplopia. That means the chances of BSV is there. BSV means binocular single vision is still there. The patient has not gone to suppression because it's very difficult to remove the suppression and retain the binocular single vision at this stage. So I wanted that child to uh, do, and I checked the vision as well. I saw the vision was 618 after the correction. So I thought that the patient should be treated with first amblyopia, so patching should be performed, and then the therapy which are I have already mentioned in the previous slide, which are binocular therapy. Binocular therapy means the patient would be having diplopia. We wanted that diplopic patient to be converted into binocular single vision. So the Broxting exercises can be given, stereogram cards can be given, so the fusion would be achieved. Prism bar exercises could be given so that he would be achieving binocular single vision for near. Distance, there was no issue because he was having esophoria. So from phoria was very little in amount. So we can definitely cure the phoria, but the main concern was he was facing double vision for near, and I don't want to, I want to cure that first. So apart from giving this +2 diopter lens in the left eye, I thought of giving the bifocal ad. Why this is important in patients who are having convergence excess or accommodative type of esotropia, which is not related to the refractive error basically. Uh, we can relax the accommodation by increasing the plus lenses. So I have done the cover test and I put the plus lenses on top of his correction and asked the patient to look at the near objects, and the patient was reading the near objects. I had started putting the plus lenses, goes on increasing till the patient will seeing the objects as single, or he was not squinting. Squinting means there was no squint present in the eye. So till that manifest squint converted into the phoria, I keep on increasing the plus lenses and gave him the addition part. So for bifocal was very important in this concept. Because plus lenses will relax the accommodation and I wanted him to achieve the binocular single vision. So I gave him bifocal glasses for near purpose, and these bifocal lenses are not permanent. As your vision is improved, as your squint has been reduced, you have to monitor the patient every after 2 weeks, first after 2 weeks, then after 1 month, and then 2 months, and then so on. So you should be having a checkup follow of every 2 weeks, see the squint condition, and then you have to reduce the near ad and along with the exercises. Exercise band nahi karna hai. If you stop the exercises in between, the patient will again land up into the same stage. So Broxting, the stereogram cards, then patching, these all exercises should be mandatory along with the bifocal ad. So bifocal ad is just to give the stimulation. that no, there is no stimulus for the accommodation. I will not accommodating, I'm not converging. So this is just a stimulation that I'm not converging, so my squint will be reduced. So for that reason, prescribing the near ad would be important in patients with convergence excess. So and then automatically the patient's response was there on all stereogram cards, then Broxting, and from diplopia, he was converted into binocular single vision. This is how I proceed with this patient who is having convergence excess type of esotropia. So I feel that the diagnosis part is very, very important. And along with the diagnosis part, your treatment part should be, or the management part is important, because here you are ruling out, or you are seeing the all aspects of the patient's condition. So here, cycloplegic therapy, cycloplegic refraction was ruled out. Cycloplegic refraction was done to rule out the patient's refractive error. Then you have gone to the cover test to see the type of esotropia, because whether the distance was more than the near or the near than the distance. Then your accommodation convergence response was there in the form of AC by ratio. So all these aspects should be considered to rule out this condition.
Yeah.
So I feel that
so there is a question by Radhika. She's asking, what is the type of bifocal that you have given to this patient?
Actually, you should be prescribing bifocals depending on the age. So if the child is of 3 to 4 years of the age, then you will be prescribing the pupil bisecting bifocals. Then as your age increases, then you can just uh, bifocal segment can be given 1 or 2 millimeter below your pupil.
Okay.
So every time it is not pupil bisecting.
Right.
So it will be depending on the age.
Also,
so lesser the age.
yeah.
Yes, yes.
Since this was kind of a unicular problem.
Yeah. So bifocal is not for the both eyes. Bifocal is for the basically left eye. Yes. Then we have to see that the response is still alternate esotropia is still there. Then you have to give the bifocal near ad for the both eyes as well. But here in this case, the mainly I have seen the esotropia was there in the left eye, and it was going alternately. But once I prescribed the bifocal lenses, the squint response got reduced from tropia to phoria. So I did not prescribe for the other eye. So it depends on your generally prescription of bifocals to both eyes would be ideal, because accommodation and convergence response, you are doing it unicularly as well as binocularly.
Yeah. So essentially the prismatic effect of the lens is in your favor.
Yeah, yes, yes. So पहले आपको देखना है, you have to just see that whether the patient is willing to accept the bifocal lenses. That is the second part, but first part is that whether that tropia is converting into folia or not. If it is there, then definitely prescribe the bifocal in both eyes.
Right.
Because prescribing for the one eye may not be helpful, as the accommodation and convergence response can be there in other eye as well. So you should be mainly prescribing the bifocals for both eyes.
Right. So I think, ma'am, we have crossed the 1 hour mark. Actually, it did not feel like such a long time, but since we have some limitation of the time as well,
yes,
I think you can just summarize your.
Yes. So I feel that you have seen the cases. From those cases, I know that you may feel that this is something uh, very difficult that I have to do it. So this is nothing like that. It's not so difficult. Once you be in the routine practice, how to perform the test, how to diagnose the condition. So it will take few minutes to diagnose the binocular vision. So I feel that there is more to vision than just having the 20/20 eyesight. So you should see that satisfaction on the patient's face that yes, because I've treated so many amblyopic children, their parents actually they don't know that how to express their emotions, because these things they were not told by any of the practitioner before they come to me, and they really thought that this is something different that we are performing and your child's vision has retained due to this therapy. So I
And
feel
the
that you
takeaway
should
message
start
of session
orthoptics
would be that
practice.
at least try and do those investigations on the
Yes.
patient. That will open up your mind on what the condition could be. And I think that's the best way to start.
Yes.
So yeah, you can share
So
your email ID, ma'am. I think the next slide.
yeah.
I think a
So
lot of people would have a lot of doubts regarding the fine nuances of the really good cases that you have presented to us. So for all our viewers, if you have any doubts, please mail Aditi ma'am. Her email ID is on the screen right now.
So I think that everyone should start at least thinking of practicing the orthoptics in their clinic from this talk. I don't know whether I was successful enough to at least create a thought in your mind for starting up the orthoptics practice in your clinic. But still, I'm hoping that you will do that. So thank you once again, Asian Eye Hospital and Hussein, for giving me the opportunity to share my experience with you all. So happy practicing. Thank you once again.
The honor is completely ours, ma'am. We have really been fortunate to have gone through your presentation. I think each and every person who is attending this particular webinar also, and this webinar will be there on YouTube, would get an idea on what kind of a skill set is required for an optometrist. Not only computer vision therapy is not the solution for all your problems. And I think that is what the discussion we had previously, that we want to motivate people to start doing manual procedures on patients so that you would physically get hold of a diagnosis. And that would really help you develop yourself as a full-fledged, because we see that orthoptics or vision therapy, people who require them could land up anywhere. It's not just in an orthoptic clinic. You would have them in the general practice also. And nowadays, ma'am, one of the things I wanted to ask you is that we have this phenomena where people of 35 years of age, 34 years of age are having this uh, binocular vision problems. I wouldn't say that, but you must be knowing that the marketing companies have removed their amplitude of accommodation, and they have started giving those pluses. So I would like your take on it, on what is the correct way for an optometrist to go about a person who is pre-presbyopic or in the age of 30, 34, 35, and he is having problems with vision. What is the correct way of coming to a conclusion, not just directly prescribing a eyes and lens or something like that?
So I feel that you should first have a normal routine eye checkup for those pre-presbyopic age group, and your first thing that you should be convincing that patient that now you are at the age of 40, and you should be explaining their symptoms in their language. So now you will be crossing 40. Now you will be having the, or you will be facing the problems for the near, or you will try to take out the some symptoms associated with their age and try to correlate these findings, and just convince the patient in a such way that see, because your muscle balance would be you are crossing 40, your muscle imbalance might be there. So we wanted to have a we request you, or we wanted to have your few minutes more, so that I would like to investigate few more. I would like to do the few more investigation, which may not, which will be useful for you in next few years, because you will be crossing 40. So we need to convince the patient in a such way that he should be ready for the orthoptic investigation. We should be correlating his symptoms. What I feel is, and doing the camps definitely would help you, but camps for pre-presbyopic age, I don't think that how many of the practitioners are doing it at regular basis, because they are doing it in the companies only. They are not going to each and every professional and um, screening all the pre-presbyopic patient. So when the patient comes to your clinic, that time there is main thing that you should convince the patient in a such way that he will ready for the orthoptic investigation. You should try to correlate their symptoms.
Right. Wonderful. So I think we have really overshot on time. My apologies to, I think we are getting a few questions, but we might not be able to take it at the moment. But you can definitely mail these questions to Aditi underscore 8729 at yahoo.co.in. She would be happy to solve all your doubts. Once again, ma'am, thank you for this opportunity for me to host an expert like you. I think this is for the first time, and
Yeah.
very happy with the talk. And I think the viewers also would be very happy. Fortunately, during the talk, we did not have any technical difficulties, and I think everything, the audio and the video was pretty clear. Your slides also were pretty clear, and you have been teaching for around 15 years now. I think the recent pandemic also has really changed the way you have adapted to technical.
It's a great honor to me as well.
Oh,
That I'm also learning from this new technology, because being in the classroom and being online, it's really difficult to manage without classboard and without chalkboard and class blackboard, everything.
right. So yeah, so we will end this talk right now, ma'am. Once again, thank you so much from Asian Eye team. We are humbled by your presence, and we will have further some lectures. I would have thought about something related to the FAO case report. How to make a case report and stuff like that. So probably we would collaborate you in the future as well.
Yes, sure.
Okay.
Yeah.
Thank
Thank
you.
you so much. Yeah,
Yeah.
thank you.
Bye. Take care.